That's what I wanted. Okay, now share screen. Now recording in progress. Share. All right. What if diabetes could be reversed for more than 6 years with a simple 30-minute procedure, the MGB2? So that's not exactly our topic, for the paper, but we know that your internet connection is unstable. Okay. We know diabetes is deadly. So the introduction of our paper, we're going to say something about that. With diabetes is the most common cause of blindness, kidney failure, amputation. Diabetes leads to heart disease, stroke, nerve damage, and more. And this is from the Endocrine Society. But here's the new news, and that is that we believe that we have data to suggest that early intervention for thin diabetics can reverse it, at least for up to 7 years, which is what our data shows. So we'll be talking about that today. Here's an example of a patient of Dr. Couloir and Dr. Magenda. And this is a relatively thin patient for being seen by a bariatric surgeon, 37 years old and 67 kilos. So our BMI is 25, or it was, and that's almost normal. And but her, at the time, this is about 7 years ago, her hemoglobin A1C was 15%, which is scary, dangerous high. She also had hypertension, obstructive sleep apnea, hyperlipidemia, and migraines. She was on insulin for 5 years prior to this, and she had type 2 diabetes for 10 years. She had the mini gastric bypass in 2018 and follow-up in 2024. So that's 6 years later, right? Her hemoglobin A1C was 4.7, which is normal. In other words, she's not diabetic. Her triglycerides had also returned to normal. She had no recurrence of her diabetes, no complications. She said improved quality of life. Her sleep apnea is gone, her breathlessness on exertion, and she was actually here for cosmetic surgery. So that's the magic we're talking about, but that's one patient. So the purpose of the paper is to review a total of 55 patients that we had for a total of between 5 and 7 years follow-up. And with results similar to this, and this one is, you might say out of the ordinary, but I think the mini gastric bypass is now relatively ordinary, and so we should use it. And that's what we will argue. And so it's a modest proposal from Dr. Couloir, that is MGB and MGB2 for thin diabetics, which have generally not been the purview of obesity surgeons. And we're going to hopefully change that with this publication. The group of the doing the report is Couloir, Magenda, and Rutledge. And this is really the first that we know of a long-term report of success treating thin diabetics. This is 52 patients with 7 years of follow-up. And again, the mean preoperative hemoglobin A1C is really in the deadly or danger zone. And the postoperative number is down to 6.1 at 7 years, which is close to normal. And so what we know is that the MGB, MGB2 can completely reverse severe diabetes for more than 5 years and often off all medications. Now, as a reminder, in India, it's a deadly disease. Diabetes is a deadly pandemic, we would say. The drugs available for the treatment can be very expensive. And the changes that they get in diabetic numbers are not what we just saw, a change of 6% percentages. What we see with drugs is around 1. And that seems rather sad, because when you change somebody from 12 to 11, they're still at risk of those deadly complications. What we're going to talk about here today is the use of an old operation that's been around for more than 100 years, and numerous published studies have shown that this operation can successfully treat diabetes, either improving it or completely reversing it. Now, We might argue a little bit during the paper whether or not this is a cure or whether or not it's reversal. Some people say cure must be permanent for the rest of your life, but I disagree because you can be cured of a cold and get another cold. And you can be cured of diabetes, in my opinion, and then have a recurrence. But we will use the terms that everyone likes, which is that you say it's a reversal and it can come back. And then we're going to point out that the MGB in this group successfully treated thin diabetics and reversed the diabetes. And briefly at the end, we'll probably talk a little bit about the MGB2, which is a version of MGB, but a little bit less expensive, a little bit shorter, a little bit safer, with a low to zero rate of bleeding and risks of leaks. So first, we're going to remind the reader of the fact that India, like the rest of the world, is in the midst of a deadly diabetic pandemic. And I won't spend too much time on it now, but for example, 77 million, one of the world's highest rates of public health crisis of diabetes. One of every 11 people has it, and this causes not just suffering and an illness, but economic strain on the individuals, families, states, and the government. And as it is projected to increase, those problems will get worse. And as we pointed out, medical treatment, although quite expensive, is limited in its effectiveness. The delta hemoglobin A1C of 1% seems anemic and inadequate for what we need in the face of this pandemic. Our next topic that we're going to bring up in the paper is the fact that we know what to do. We can just look at the medical records published, and they show us that Bilraw-2 routinely improves diabetes, even if it doesn't cure it, so to say, cure. But in many cases, it reverses the diabetes. And that's all we're doing in this study, is reporting that this known information was applied to thin diabetics with success. I was going to say fantastic, unbelievable, superb. I don't know if the adjective is appropriate, but the results in this presentation are that the patients did very well with normal hemoglobin A1Cs in 95% of patients. But again, just a reminder how old this operation that we're recommending is. 1885 was the first Billroth 2 by Theodore Billroth. That means over 100 years. And this is not something new. It's not something untested. We know about this. It just really, for some reason, hasn't been used. If you look on PubMed, there's more than 100 articles showing Billroth 2 operations improve or reverse diabetes. And again, what we're talking about here is a really remarkable, not a minor or small change, but 6.1 is close to normal. And 12.6 is so high that we face very high risks of the deadly complications. And the deadly complications, again, are blindness, heart attack and stroke, amputation, kidney failure. And none of these are minor. These are tragic and deadly complications. And imagine that they could be addressed for the long term on a relatively inexpensive operation that we've known about for 100 years. Here's the raw data that we'll be presenting, and we have more detail to go into. But the preoperative hemoglobin A1C is in the 13 range, and the 13 range is a deadly range to be in. Within the first year, the average was down to 7, and then 6.7, then 6.4, 6.2, 6.1, and that's in the normal range. In other words, I don't know we're allowed to say cure, but that is amazing as far as predicting the risk of the deadly complications. And here we can just see it a little more clearly. This is another graph of the same thing. And basically, there's only 3 out of the 55 who didn't reach 5.4%. In other words, they're all less than 7. And I mean, then 5.4% were greater than or equal to 7. And that's this person here, a 7 plus, 7.5, and one at 8. And all of these are much, much, much better than 12.5. This is a life and death difference. Here's another look at the same kind of data, saying that basically as people get older, we're less able to, quote, cure the diabetes. But you can see the timing of diabetes interferes with the successful resolution of diabetes. So one of the take-home messages we want to make in the paper is simply operate early. I think there is a widespread opinion that delaying operation until necessary, like a last-ditch effort, is a strategy many physicians use. And we think here, this tells us that you take away their opportunity for improvement to the near normal zone. If you see the blue box on the left, those people are in the normal zone, but they had, as you can see in the x-axis, they only had the disease for 5 to 7 years. When you have had it for more than 15 years, it becomes harder to cure, and that makes perfect sense. So we're arguing in this paper not only the good results that we see with the MGB, but also that we should learn how to manage it better. And management means, in part, we think, operate early. The other thing is we want to point out in the paper something a lot of laymen and surgeons don't know, which is that pancreatic failure by the beta cells is measured in the C-peptide. And one of the things we want to point out why the Billroth-2 is so effective is because it's able to block saturated fat absorption. And now we know that the C-peptide drop is coming from fatty food intake, which damages the beta cells. And we can measure that by measuring the C-peptide. That becomes important, as we'll see in the next couple slides. We think you should operate early before the damage occurs. And the damage occurs over time because saturated fat damages the beta cells. And the beta cells are where the insulin comes from. And when they are shot, it becomes hard to cure. So this is another example. And what we see here on the left, this patient had a hemoglobin A1C after treatment of 8. And you can see over to the right-hand side, they had lower, and they had higher C-peptide. That is, they had more beta cells working, and we were more likely to be able to cure them and reverse their surgery, or reverse their disease. What we're saying here is, again, what we said before, that early intervention before the disease can kill the pancreatic beta cells, then we have a chance of curing that patient. And so that's what this graph tells us. And we see that once they are down around 0.5, the improvement is very limited. They still get an improvement, but imagine they miss the freedom of being a normal diabetic, a normal patient with diabetes, or a normal patient, maybe some people would say cured of diabetes. I know we're not allowed to say cured. Again, this is just the same thing, just to try and point out there's a bad group here. They had low C-peptide. That means their beta cells were harmed. They were killed over time by the high-fat diet. So one is, of course, don't eat a high-fat diet, but also don't wait. That's our opinion, is the conclusion from this paper. So the normal peptide is between 0.5 and 2. When you are less than that, our success of cure declines. Act before the low C-peptide, less than 1. Act before that. The other thing is just in general, aging. And that's the same kind of damage. And so that the younger people have lower on average HbA1c in the range of normality. Imagine that we could cure and reverse diabetes. What if we could cure diabetes? It seems we have better likelihood of that if we were able to operate sooner. Now, we chose the biliopancreatic limb length based on weight, but we didn't find it made any difference. So we won't talk about that very much, but there's a lot of discussion in the literature that you should tailor the BP limb length to the weight of the patient, but we did that in this case, but without any effect. So we're not going to mention it too much more. Here's the study. It showed that based on the weight, we chose a longer BP limb length, but there was no association with the results. This is the BP limb length and the percent hemoglobin A1C. You see for worse disease preoperatively, we chose a longer bypass, but there was no statistically significant association. This is just a scattergram. So basically, every one of these patients could have just taken an average BP limb length if our data is correct. No association of BMI and delta hemoglobin A1C. So it's not the weight in this category. Another question is, well, we're frightened. We can't do a bypass surgery like bariatric surgery on a thin patient because they'll have malnutrition, and that a lot of people fear low albumin levels. So we did measure that, and here are those results. And you can see that the bypass limb length, as it was longer, there was a slightly more decrease in the albumin level, but they were all normal except for one, and only one was even slightly low. So basically, all of these patients for 7 years, their albumin would remain normal. And it is true that the longer BP limb had a slightly lower albumin, so it might be reasonable to shorten up on that BP limb length a little bit, but none of them were harmed by the longer BP limb length except the two people here with the red circles. There was no association between the preoperative BMI and the preoperative hemoglobin A1C. So weight did not predict the outcome. It was the disease underlying, and it's not just obesity. In fact, they weren't obese. So this is the R squared. So it shows there's no association between the preoperative hemoglobin A1C and the preoperative BMI. And we also were frightened of BP limb length. Oh my goodness, we'll have maybe vitamin deficiency. So we measured B12 layers. And B12 was not associated with the operation. In fact, it turns out the patients had a better, higher B12 level after the surgery. And how can we explain that? Well, the bypass didn't make much difference, and they were probably forced to eat more healthy, more fresh fruits and vegetables and whole grains and other foods that would be healthier for the body. Another important point is everybody, and I exaggerate a little bit, but almost everybody has a good, healthy weight post-op. So they went from slightly high normal to exactly mid-range. And so that's a very good place to be. The next thing we wanted to know is, could we assess the impact? In other words, what do these numbers mean? So we partnered with Google Gemini, and we did linear models of some of these numbers pre and post-op and outcome variables like costs. And so these are not real numbers, but they are predicted from public data using Google Gemini. So let's look at it a little bit. So comparing the estimated and projected costs. In other words, how much does it cost to take care of a diabetic? And there's a number of studies that suggest it's directly related to how bad the disease was, that is the HbA1c. So if you have high HbA1c, studies suggest that it's going to be more expensive to care for you because you'll have more serious and worse illness. So if we put that into the linear model, then what we can say is the high costs, which are medications and supplies and monitoring and treatment of the complications, we can actually get a predicted cost. Now, this isn't precise, but in general, it's common sense. So if we said your hemoglobin A1C was less than 7, most of our patients post-op, the model that we created with the artificial intelligence said that the yearly cost for caring for that diabetic was 20 to 30,000 rupees, or about 375, 250 to 375 US dollars. If your hemoglobin A1C is between 7 and 9%, that'd be 30 to 50,000. And if you're greater than 9, then you see there's quite a jump between 50 and $80,000. So if we take those numbers now, and now let's look at the pre and post-op values. Remember, preoperatively, our patients had a hemoglobin A1C just above 12 and postoperatively just below 7. So if you look at those numbers, that means that the cost of the same group of patients preoperatively who have a high HbA1c would have been between $6,000 and $10,000 compared to a lower, below 7 HbA1c, which would be 2 to 3,000. So let's take that and extrapolate that for 7 years and say, and we're 10 years, HbA1c less than 7 versus HbA1c greater than 9. Well, then the cost is the estimated 10-year cost for less than 7 is $20,000 to $35,000. And the cost for HbA1c greater than 9 is 60 to 100,000 US dollars. So the potential savings of this model, this is not perfect, is that the savings per patient would be $40,000 to $65,000 per patient. And that number, maybe you say you don't care about the number, the dollars, but that's dollars of pain and suffering also. It's pain of complications and serious illness. Imagine if we could make a difference in those things at that level. So here's another way to look at it. We said pre-op 10-year total. If you were those numbers that we saw pre-op and along the bottom here, 10, 11, 12, 13, 14, 15 HbA1c, the estimated 10-year cost to care for that patient was $2.8 billion for that group of patients for 10 years. The post-op group, not quite $1 billion. So the savings is close to $2 billion medical dollars. And again, think beyond just the dollars. Think of the suffering that that must be paying for. Now, if we do it just for that group, we say, now, 10 years of medical costs with and without surgery. So you estimate the 10-year medical costs for 55 patients, $4 million. And the estimated 10-year medical costs for the 55 with HbA1c less than 5, that's $1 million. So the savings here, estimating it by individual, it's $2.8 million per patient for 10 years. Diabetes is a deadly disease, and so there's 100% risk of cardiovascular disease when we studied this. So in other words, what we asked is there are studies which predict the risk of, say, a heart attack or a stroke, cardiovascular disease, based on the hemoglobin A1c. And here this graph is kind of hard to read because, and let's start with the post-op patients. Remember, the post-op patients had less than 7. So the predicted post-op risk of having a heart attack or a stroke in those patients when they were HbA1c of 7 is 0. Now, what about for the numbers of those patients, their numbers they had before surgery, their preoperative numbers? You see the number 100 is circled. That means the percent predicted risk by this model says every one of those patients are likely to have a heart attack. So we go from everyone has a heart attack or a stroke to no one by the surgery. To me, there's no more justification needed for doing the surgery. You will have a heart attack and you may die with that, or you won't. And the surgery makes the difference. So knowledge and experience with the MGB, the selection criteria operate early. We think the data shows treat all the ages, young and old. And Coular's data says we will go on average from 12 plus to less than 7 and 95% of patients. Our conclusions then, it routinely, Bilbra 2, routinely improves or reverses all diabetics, but we've known that for 100 years. A short BP limb with minimal or no deficiencies, a 20 or 30-minute surgery if it's an MGB2, safer, more effective, and cheaper than medication. So we say operate early, and our cry is save the beta cells. Okay? Now we have to, that's not a paper, it's just rambling. But let's get that all typed up and then send it to you. I forgot all about that. Okay, so now go escape. Stop sharing. Sorry.
Sorry for being sick.
No, I'm sorry you're sick. I am very sorry. Now end me.